Dr. Sandeep Singh and Rotablator.
Respected Chairperson, ladies, gentlemen, good afternoon. So I have to present on a topic which is a complex scenario, how I got into and out of trouble during Rotablator. So my focus will be more, actually this NGO will be more from a point of view how I got into, though I did definitely got out of trouble also. So this is a 65-year-old lady who had a double vessel disease with a disease in circumflex, a discrete lesion, and a lesion in the RCA. As you can see here in this NGO, that the RCA lesion is calcified. It's a long calcific disease, and there is a significant disease just where the pacing lead is cutting the right coronary artery. You can see that there is a tightest spot. You can see it in the other view also, that there is a calcium starting from proximal to mid segment. So we decided to do a rotablation. So we took a 1.5 millimeter burr at a recommended speed. We started doing rotablation. With the packing movement in the mid RCA, we negotiated the tightest point, gave a polishing to and fro run. Everything went very easy as of now. This is what happened. Put on Dynaglide mode to take out the burr. Burr got stuck. Surprisingly, the burr got stuck in the proximal segment. Generally, it is known that the burr generally gets deep embedded if you are not doing proper rotablation in the site of the lesion. But here, it got stuck into the proximal segment of the RCA. If you can see, I will play this NGO. Important point to note is that we wanted to rule out any bend in the wire, so the wire was freely moving. The burr was not coming out, but it was moving forward. As you will see shortly, that still the burr was able to move forward, but it got stuck near the ostium or in the proximal segment of the RCA. Before I really go into the details, why exactly it happened, I would like to emphasize here that majority of the complications during rotablation, what's available in the literature is that the burr gets embedded in the lesion itself because it's not a proper rotation, or you're not taking care of packing movement, or you are not taking note of the drop in the rotation. Because of the embedding, generally if you try to do a manual pulling, it results in grave consequences. There are so many ways by which you can handle this. By putting a guide extension, you have to disassemble the rotablation by cutting it, taking out the sheath, and try to put another wire, dilate it with the balloon that particular area, and try to take out the balloon. But less is known about the other fact, which perhaps was the case in our was seen in our case. Now, this is called as the Kokesi effect. This is on the name of a Japanese doll. Here, what happens exactly is that you can go distally, but you cannot come proximally. So, for the sake of clarity, I'll again run the NGOs again, and now I'll try to emphasize what went wrong. So if you can see here that there was a lesion in the proximal segment, there was a bend in the proximal segment, and then there was a tight disease in the mid RCA. And when we burred, in the initial part, we tried to force the burr from the proximal segment. Now, if you are using a smaller size burr, by sheer pressure, or if you are slightly rough, it will go distally. But this does not mean that this has debulked the proximal part of the lesion. It has just gone because of the shear force. And because the proximal because the tip of the burr is polished, so you can go distally. But what happens is that once you are trying to come out of that particular area, since the proximal portion is not properly debulked and the back of the burr is not properly polished, it gets stuck over there. How to manage this particular problem? So generally what happens that since you are able to go distally, generally there is no hemodynamic compromise in this patient, because moment you will go distally, what happens that the flow is established in the artery. In this particular case, the patient did complain of some chest pain, though there was no significant SCT changes or there was no hemodynamic compromise in the patient. What exactly we did in this patient? We gave a lot of nitrates, intracoronary nitroglycerin to the patient. We increased the speed of the rotablation, and then with a deep throating of the guide, we tried to take it out. There was definite tug. We were fearful that it may perforate the artery, it may cause rupture, and then that's a day for you, because patient has to go for the surgery. We were lucky enough. The other options definitely could have been passing another wire by the side of the burr and try to inflate a balloon so that the burr gets disengaged from the area where it has got embedded. So the idea of presenting this case is to know that whenever you are doing a burr, you have to be very careful, you have to analyze the whole lesion properly. So once we realized that once we took out the burr, you can see that there was no perforation, there was no major dissection. So we went ahead and did a rotablation burr, again 1.5 millimeter. Now this time we were very careful that we do a complete polishing run starting from the proximal to the distal segment, as you can see here. And at the end you will see that we have given a definite polishing, debulking runs in the proximal segment also. Then the life after that was very easy. We did a balloon dilatation. You can very well see in the balloon also that there was a significant bend also. Only this is seen when there is a bend along with the calcium in that particular segment of the artery. Then after that we stented, and this is the final result. So take home message is that whenever there is a long calcified lesion, you have to adequately debulk the whole length of the artery, especially if you are seeing a dense calcium in the proximal part, and especially if you are taking a smaller burr and if the proximal lesion doesn't look that tight, because while coming back you may get trapped over there. Never park the burr in the calcified zone. With small burrs, keep in mind the Japanese Kokesi effect. Actually, if you really see on a lighter way, it reflects from a Mahabharata epic more like a Abhimanyu, that a small aged character gone through a toughest phase and can take rounds and rounds but really cannot come out of that particular zone. And always keep all the hardwares for rescue available during a complex case, especially if you are doing rotablation, because you don't know when you will be caught unawares during a simple looking case. Thank you for your kind attention.
Thank you, Sandeep.